Hello everyone, welcome back to my YouTube channel Speedy Dentistry. Today we'll be learning about OSA, which is basically obstructive sleep apnea. It affects 2 to 4% of population, and what it is, so basically it is daytime sleepiness along with loud snoring and witnessed breathing interruption or awakening due to gasping and choking in presence of at least 5 such events, that is 5 obstructive events per hour of sleep. What is obstructive events? It can be apnea, hypopnea, or respiratory effort related arousals. The causes of which can be neurological, cardiological, abnormal anatomy, and abnormal muscle physiology. So, physiology, anatomy, or neurological or cardiological causes can be seen. For the risk factors part, it affects the middle aged man who are obese and having craniofacial anatomy disturbances, genetic causes, alcohol and smokes, and medical comorbidity. So we can remember this using this image: middle-aged man, obese, sleeping while smoking, alcohol consumption. So this is the risk factors for obstructive sleep apnea. Now coming to the indexes, so respiratory distress index, it includes the apnea, hypopnea, and respiratory effort related arousal. For the Epworth scale, it is given score 0, 1, 2, 3. 0 stands for never doze, so that the patient doesn't sleep. 1 stands for slight chances of dozing, moderate chances of dozing, and 3 is for high chances of dozing. For apnea hypopnea index, that is AHI, in this adult, for normal less than 5 episodes of apnea, mild is 5 to 15, moderate 15 to 30, and the severe are more than 30 episodes of apnea. For pediatric patients, it is given as 1 to 5, 5 to 10, and more than 10. Now, how the cycle starts: once the patient is in deep sleep, the airway muscles relaxes. So the muscles are relaxed, leading to closure of the airway. Due to closure of the airway, the blood oxygen significantly reduces and heart starts to compensate and pumps faster, leading to increase in the blood pressure, which alerts the brain, and thus choking and gasping is produced, leading to disturbed sleep. Again, the patient went to sleep and the cycle continues. So the sleep apnea cycle occurs 10 to 300 times per night. So next, coming to the spectrum of disorders, first snoring is seen, then the upper airway resistance syndrome, and finally the obstructive sleep apnea. Coming to the signs and symptoms, so we have seen in the definition there will be disruptive snoring, witnessed apnea, choking while sleeping, and increased daytime sleepiness, irritability will be increased, and loss of libido, that is the sexual desire, will be decreased. Now coming to the stop bang interview, it will be for S, we'll ask if he have noticed any snoring or any other one has observed. T is for tired, O is for observed effects, P is for pressure, that is the blood pressure will be raised. Now for the bang interview, B stands for BMI. We'll check the BMI. If it is more than 35 kg per meter squared, the chances are raised. Age for more than 50, neck circumference more than 40 centimeters, and gender, in male patients it is commonly seen. For the imaging part, we go for DISE, that is drug induced sleep endoscopy. So we'll basically produce the endoscope when the patient is asleep and the sleep is produced by or induced by the drug. So first one is DISE. Next, the sign magnetic MRI, that is sign magnetic resonance imaging, is done. CT scans are done, cephalometric analysis, and lateral neck films. And the most common or predominant imaging used is polysomnography. In this, we attach a scalp electrode to the patient's head to read the brain activity, at the chest to study the heart activity, at rib and abdomen for the respiration. Also at the hand to observe the muscle movement. Pulse oximeter is attached to see the oxygen saturation, and airway sensor at the nasal aperture for the respiration. For the diagnosis part, once we have finalized that patient is having OSA, we go for behavioral treatment. In behavioral treatment, we advise the patient to lose weight, increase the activity, and avoid the alcohol and smoking. Then we go ahead with the CPAP machine, that is continuous positive airway pressure. If it is well accepted by the patient, we go ahead with evaluation and adherence to the CPAP machine, and then we study the outcome. If it is positive, then follow-up is done. If there is no effect, then we go for the alternate treatment. Also, when the patient is non-accepting the CPAP machine, we go for the alternate treatment, in which we are having oral appliances, surgical methods, and adjunctive therapy. For the oral appliances, first one we are having is tongue retaining devices. So we'll retain the tongue, and second one is mandibular repositioning devices. So one way is to retain the tongue to increase the airway, and second is mandibular repositioning. For the surgical part, for surgery, first remember the first and last one. First, second, third, fourth, 5 and 6. So we are having 6 modalities. First one is bypass. So we'll do the procedure to bypass the upper airway, that is we'll directly insert a tube at the trachea, that is tracheostomy. For the sixth one, global airway procedure is done, in which MMA is there, that is maxillomandibular advancement, that is we'll advance both maxilla and mandible, and it is most successful and versatile procedure done. So first and last are clear. Next, coming to what we can do the nasal procedure, oral, oropharyngeal or nasopharyngeal, hypopharyngeal or laryngeal procedure. For the nasal procedures, we are having rhinoplasty, septoplasty, turbinate reduction, and nasal polypectomy. For the oral, oropharyngeal or nasopharyngeal procedure, the most accepted treatment is UVPPP, that is uvulo-palatopharyngoplasties. So uvulo-palatopharyngoplasty is done, and next treatment modality is tonsillectomy. For the hypopharyngeal procedures, we can go for genioglottal advancement, mandibular advancement, or tongue reduction. For the laryngeal procedures, we are having epiglottoplasty. Thank you for patient listening. Stay tuned for more.